Hello, my name is Dr. Kathryn Malin. I'm an assistant professor in the College of Nursing, as well as a fortunate recipient of a faculty fellowship from the Institute for Women's Leadership here at Marquette University. I'm very excited to share information about a project that my team recently completed entitled The Impact of Social Determinants of Health on Infant and Maternal Health Using a Reproductive Justice Lens. My team sought out to use data from the Pregnancy Risk Assessment Monitoring System, or PRAMS database, to evaluate relationships among social determinants of health and infant maternal health outcomes. Uniquely, though, we were attempting to do this while also incorporating a conceptual framework that included concepts of reproductive justice. Before I get started, though, it's really important to sort of ground ourselves in the current state of infant and maternal health in the United States. The United States continues to be the most dangerous developed country to give birth. With a mortality rate of 22.3 per 100,000, the United States is more than 50% higher mortality rate than the next closest country studied. Black women in the United States have a mortality rate more than double that of the country's overall mortality rate. And while there are many drivers for these poor outcomes, it's really important to remember that many of this comes from modifiable and social risk factors. One such example is the presence of maternity care deserts. Maternity care deserts are areas in this country where access to maternity care services are severely limited or just non existent completely. These regions often lack hospitals, birthing centers, or OB providers, making it very difficult for people of reproductive age to receive prenatal, delivery, and postpartum care. Maternity care deserts are much more oftenly found in rural areas and other underserved areas throughout this country, contributing to higher rates of infant and maternal health complications. The March of Dimes defines maternity care deserts as counties without a hospital offering any OB services, areas with no counties with no OB providers, and no birth centers at all. In order to address modern health disparities, it's really important that we use modern day frameworks to guide this research. Theories are really important because they help us understand relationships and behaviors. And for our study, we utilize the Restoring Our Own Through Transformation theoretical framework. You can see this here. This framework is rooted in reproductive justice. And sort of just as a reminder, reproductive justice is the human right to maintain personal bodily autonomy, have children, to not have children, and to parent those children in safe and stable communities. The Restoring Our Own Through Transformation is a Black woman led reproductive and birthing justice organization dedicated to collectively restoring well being through self determination, collaboration, and resources. Root was founded by Jessica M. Roach. And if you're interested, you can go to their website for much more details about their framework and the work that they're doing at rroottrj.org. This framework here is organized to explore how social and structural determinants of health can impact maternal and infant mortality. In this image, you can see that the social determinants of health are in the circles. As a reminder, social determinants of health were launched over 10 years ago by the World Health Organization as a commonly described as the conditions where people live, work, and play. This is represented by constructs such as education, housing, neighborhoods, and so on. But when we consider health disparities such as maternal mortality in the United States, we must consider that there are deeper forces underlying the distribution of health inequity. There are structural determinants here in this framework that are depicted in the boxes. These structural factors, such as slavery, Jim Crow law, redlining, are really unique to the United States and are important contributors to maternal child health inequities. This framework is central to our study design, and we conceptualize the interplay of social determinants of health and maternal child health. Using this framework, we were able to identify variables within the PRAMS database that aligned with these central concepts and were measurable, allowing us to evaluate relationships among these concepts in a much larger sample. Our team received approval from the CDC to access and use data from the PRAMS database system in the spring of 2024. The PRAMS database was created by the CDC as a tool to collect, analyze, and disseminate population based data from all over the United States. Data for PRAMS comes from several sources, including birth certificate questionnaires, questionnaires sent out to birthing persons and healthcare providers about things like income, pre-pregnancy health, pregnancy intention, birth outcomes, and many other important variables impacting the health of infants and mothers throughout our country. The PRAMS 8 database includes data that was collected between the years of 2016 and 2022. For our study, we only used complete data from 11 states that included the Social Determinants of Health supplement, which really allowed our team to identify variables that aligned with that ROOP framework that I described in that last slide. In the end, our weighted sample included data from over 430,000 birthing individuals. Data from this sample was similar to those found in other national statistics, with 9% of infants who were born requiring hospitalization in the neonatal intensive care unit, or NICU, and 9% of respondents reporting gestational diabetes. Our team assessed several social determinants of health and many covariates that are associated with infant and maternal health outcomes. Using bivariate analysis and multiple simultaneous regression models, we were able to identify the most significant predictors of infant and maternal health using a reproductive justice framework. The main outcomes that we were interested in included incidence of NICU hospitalization, gestational age at birth, breastfeeding ever, gestational diabetes, and gestational hypertension. The data and the results were rich with information in the state of health of infants and mothers throughout the United States. Importantly, in our final model, we found that abuse during pregnancy, access to any prenatal care at all, secure housing, and education were salient predictors of poor infant maternal health. Specifically, we found that birthing individuals who experienced abuse during pregnancy are 2 times more likely to have an infant requiring hospitalization after birth in the NICU, and their infants were born approximately 4 days earlier. And while 4 days might not seem like many, it's important to remember that any day of gestation is important for an infant's development. We also found that birthing individuals who do not receive prenatal care are 2.6 times more likely to have an infant requiring hospitalization in the NICU, and their infants were born approximately 1 week younger in gestational age, and they were much less likely to have ever breastfed than those who received prenatal care in the first trimester. We found that individuals who reported difficulty in paying their rent and mortgage in the last 12 months were more likely to deliver their infants at a younger gestational age, and those worrying about losing their place to live were less likely to have ever breastfed. Finally, level of education was positively associated with ever breastfeeding. Specifically, we found that birthing individuals with a bachelor's degree or higher were 3.8 times more likely to ever breastfeed than those with less than a high school degree. While our findings are still being discussed and analyzed, it's important to realize that these predictors are modifiable, offering many opportunities to intervene and improve the health of infants and mothers throughout the United States. Thank you.